Dear colleagues, this cataract can be called a pre-intumescent cataract. There is convexity of the anterior surface of the cataractous lens, though there is no fluid cleft in the anterior portion of the cataract. I've taken up this case for surgery. Let us watch the surgical steps. I've made a side port first at around 8 o'clock in this case. I've injected air and then trypan blue dye, and now I am washing the dye out of the anterior chamber. Now I inject HPMC, that is hydroxypropyl methyl cellulose, do one more side port on the left side at around 1:30 o'clock, and this is the main incision at around 11 o'clock. And now some more viscoelastic substance is being injected, and these air bubbles are being replaced. And now capsular Rhexis is to be done. I am thinking of whether I should do 2-stage Rhexis or not, because the anterior capsule is convex. But since it didn't appear to be intumescent, since no fluid was coming out after making a puncture, so I tried to do Rhexis at on go. Now see what happens here. Here it goes to periphery just in front of the main incision, and I cannot recover it. I inject some viscoelastic substance over that area. Take the Utrata forceps again. Try it for a couple of times to retrieve this capsule. Try to bring it towards the center, but I cannot. So I ask for a Vanna scissor. I take the Vanna scissor, make a big cut here, and then from that point we go towards the center and remove this capsule. Now hydrodissection is being done. Now I am expressing the fluid wave out. The fluid wave is coming along the equator anteriorly, but I don't rotate the nucleus because there is Rhexis is not, it's not a CCC, it's not a continuous curvilinear capsular Rhexis. The Rhexis has gone to the periphery. There is discontinuity. So I take it as a no hydro Phaco. I've done hydro, but I'm not rotating the nucleus. So I made two cuts on triangular nuclear piece, became free. I take that out. I make another chop here and take this fragment out, hold it here again, try to hold it, but I could not. Now I am moving the nucleus very gently. I always keep in mind that there is discontinuity in the Rhexis. Phaco power used in this case was 65%. Flow rate was 30 ml per minute and vacuum was 300 millimeter of mercury. I usually use 45 ml per minute flow rate and 450 millimeter mercury vacuum, but in this case I decreased the parameters. And bottle height was also kept a little down. I have managed the nucleus. Now I inject viscoelastic substance. Now I use Simcoe cannula to remove the cortex. The flow has been reduced, inflow, irrigation has been reduced. I'm keeping the antechamber formed. Very gently, very slowly, patiently, I'm removing the cortical matter. Dear colleagues, we must be very patient. We must not hurry up when the Rhexis runs out and when we cannot retrieve it. Phaco is possible, but we have to be gentle. In this case, I have taken enough precautions to do Phaco. And now viscoelastic substance is injected. I have increased the main incision to about 3 mm, which I have edited out. Now I am implanting the intraocular lens in the bag. I make sure that the haptics are posterior to the anterior capsular rim. Here goes the trailing haptic behind the anterior capsular rim. And I place the lens in such a way that the point where the Rhexis ran out is 90 degrees away from the haptic optic junction. And now I remove the viscoelastic substance. Thorough cleaning of viscoelastic substance is a must if you want a quiet eye, normal intraocular pressure in the postoperative period. And now I'm using the irrigating probe to irrigate out some more viscoelastic substance. Now see, as the viscoelastic substance come out, the clarity of the antechamber is increasing. That's it. After this viscoelastic cleaning, I hydrate the side ports, which I have not shown in this video, form the antechamber like this, and conclude the case. Thank you very much for watching this video. Hope this video will help you in managing cases where Rhexis runs out.